Hello, folks. My name is María Valle Coto, and I'm a second-year medical student at the University of Illinois at Chicago College of Medicine. And today I'll be presenting on an educational intervention my colleagues and I developed to address language in healthcare. Over 67 million individuals in the United States speak a language other than English at home. And per census estimations, at least 37.6% of them do not speak English proficiently. When these individuals become patients, language discordance, which happens when physicians and patients lack proficiency in the same language, leads to suboptimal communication and poor health outcomes. Despite national and state legal requirements, medical students often lack training and education to navigate linguistically discordant patient encounters. Medical education, particularly preclinical education, represents a critical time for students to learn how to appropriately communicate with linguistically vulnerable patients. With this in mind, we designed an educational session targeting first-year medical students. The session was taught as a mandatory class and included 2 hours of pre-readings, an hour of live didactics, followed by an hour and a half rotating breakouts, which feature 4 case vignettes highlighting language-related healthcare dilemmas. All of these led by trained multilingual facilitators. There was an optional pre- and post-session survey given to students to assess their self-reported non-English language skills, attitudes and confidences regarding language and health, and to get session feedback. Our objectives for the course were for students to become acquainted with the concept of language discordance, concordance in healthcare, its impacts on patient outcomes, to become familiarized with legal requirements for language accessibility in healthcare, and for them to leave with some proposed strategies to improve language accessibility in their future clinical settings. Overall, 182 students participated in our session, with 176 completing our pre-session assessment. 91 completed our post-session assessment, and there were 36 non-English languages represented by 133 students, with Spanish being the most common secondary language. In Figure 1, you can see the language breakdown across participants. Although a majority of students reported some degree of multilingualism, only 24.4% of them responded for speaking that language at a high proficiency, very good or excellent, and being able to use that language fluently in a healthcare setting. We asked 2 questions in both our pre and our post-session surveys to assess participants' knowledge about healthcare and language, and their preparedness to address language issues with linguistic minorities. Both were rated on a 1 to 4 scale, with 1 being strongly disagree or unprepared, and 4 being strongly agree or very prepared. Both variables showed a significant increase, and both changes supported our original objectives. The post survey also asked our students how they plan to use what they learned in our session. The 3 replies above really stand out because they highlight the root of what we were trying to do. Teach our students to recognize our own shortcomings in medicine when it comes to language use and patient outcomes, as well as empower our students with knowledge to do better by their future patients. As I mentioned before, regardless of pre-existing language skills, all medical students can benefit from taking training about caring for linguistic diverse populations. While our intervention is a successful standalone session, we are working to create periodic curricular integration of this topic for our preclinical students. Future sessions will address topics like proper self-assessment of second language skills, as well as learning to work with medical interpreters. Overall, our session fills an important gap in equity-focused communication skills training for physicians. With everything else said, this was your main takeaway for students, and I hope it is for you as well. Language is not a patient limitation. Rather, there's an issue with our systems not giving linguistically diverse patients the equitable care they deserve. And there's no better way to start changing these systems than by properly educating our future physicians. With that, I would just like to thank UIC, the doctoring and clinical skills team for letting us incorporate the session into the curriculum, and all the students and faculty who made the session a success.